difficult conversations of complicated reconstructions to get him to proper balance and full rehabilitation. So I noticed with wider, more complex clefts, generation after generation, we're seeing the exact same results. Certainly my results were the same. So I decided to change my philosophy and decided to question every aspect of conventional reconstruction and basically put together what I call the buccal flap approach, because the buccal flap is really the key for me to understand this. Individualize your reconstructive planning. You're not going to have the same operation in a Buccal 1 as a Buccal 4. You're going to diagnose and have a tissue replacement technique. You're going to reduce scar loading as much as possible, and you're going to put your muscles in the natural velvet position with little scarring. So embryologically, we're missing tissue, we're missing bone, we're missing mucous membrane, we're missing the tensor veli palatini aponeurosis, palatine bones. And yes, the buccal flap is a big key. It's not my only flap that I use, but it is very good in lots of areas. You can see it's good for replacing mucous membrane. The tensor veli palatini aponeurosis is already described. It is not good for the muscles. The muscles we can't replace, so we can't scar them. So in 1985, I put the Z-plasty with the buccal flap together, and that is where we basically add tissue to the center part of the palate, add it to the back part of the palate, rearrange the velum with the Z-plasty, and that way I can minimize relaxing incisions. It's going to look something like this in a Buccal 2, where you add the tissue, you've got a Z-plasty, you've got buccal flaps going on the nasal side and the oral side. When they're healed, they look very healthy. Here it is before the flaps are divided. No stress on the rest of the maxilla. In a Buccal 4, you can add a lot of tissue, very healthy tissue. Initially, I was just thinking that this was going to make my speech better, because that's what we all wanted. We really, as has already been said, we have to have these kids speaking well. But then over the years, I noticed that actually they had a lot less cross bites, and so then I started to think maybe it would help with growth. The no-touch approach, designed in 1987, is basically my palatal lengthening procedure done primarily. I use it primarily for the Pierrot Van kids who have a lot of times very hypoplastic muscles, and that's what this looks like. Here's how you do it. You basically do a release of the unit without putting a lot of scarring on either side. Even at furlough, you're taking the muscle off of one side, the mucous membrane is stripped off of it. Here you just relieve both the mucous membranes on both sides. You put it back to its natural velvet position. You reconstruct the nasal side to reconstruct the tensor veli palatini, and then you add another buccal flap, and that's what it looks like. So when you see these type of clefts, where your uvula is bigger than your entire velar unit, you know you don't have much muscle there. And so this gives you an opportunity. It's the one time you'll see me do relaxing incisions because my arch is intact, and I can add a lot of buccal flap tissue. You can see here that the velum is about 3 millimeters. That's all the muscle you get to use, but the child can come back 11 years later. You can see how much the buccal flaps have stretched out. The velum, interestingly, is the same size, but the speech is entirely normal. Can't do this for me any other way. So looking at a generation of kids using the Z-plasty and buccal flap approach, its speech results, complication rates, and jaw surgery recommendations with good distribution of all the characteristic classifications. Our non-syndromic group is 93.4% successful achieving normal velar function and normal speech, with a 6% need for VPI surgery. We did a comparison analysis recognizing that all of us do well with our Buccal 1s and small Buccal 2s, these patients, and we compared them to these patients. How did we do? Well, looking at that, statistically, we did the same. So now we can take a child with a Buccal 4 and mom comes in, I said, you're going to get the same results. You're going to get 93.4% normal speech. How about secondary surgeries? Actually, the furlough group had a little higher percentage of secondary surgery, which I thought was interesting. So they actually did about the same amount of VPD surgery. What about complications with the buccal flap approach? We're just finishing a review of looking at this group. We had 30 fistulas, and what were those? Well, you can say our complication rate in non-syndromic, non-Buccal syndrome kids is 4.8, maybe your fistula rate is only 3%, but not all fistulas are the same, as I said, and our fistulas greater than 2 millimeters are only 1.8%. And if we look at the group, all were able to be closed with just rearrangement of local tissues in 2 layers. All but one was able to be closed in a single operation, and that was my mistake because I did it too early in my 2nd year in practice. And none of the patients required any external flaps. We had 0 nightmare fistulas. So I do say there's a difference in the fistulas and complications you get. So now even with our larger fistulas like this, they're more of a nuisance than a nightmare for me. Growth, as I said before, I started to recognize these kids did better, so we started to look at what that means. And here's a child with acceptable occlusion, good facial balance. The other child has relatively good facial balance, but her occlusion's not right, so she'd be recommended for jaw surgery. And our recommendation rate runs now about 8.3% in the wider class. So let's look at the eye test. Let's look at these kids, because when they did grow up, I started to notice that their facial balance was better. So let's look at a series of kids who are both 3s and both 4s, who only had cleft lip surgeries, only had a palatoplasty, of alveolar bone grafts and rhinoplasty, no secondary speech surgeries, and no jaw surgeries. So you can take a child like this with a wide both 3 like we saw before, but at skeletal maturity, he certainly has a different facial profile. That's what a buccal flap will look. Sometimes they stretch out flat, sometimes they don't. Or this. There's the flap, there she is, there's her occlusion, there's her facial balance, normal speech. This child, there he is, normal facial profiles, good occlusion waiting for his dental restoration. Bilaterals, you can get this results. Good facial profile, 30-year follow-ups. Here he is after his rhinoplasty. Don't know if she's going to sing for us. We'll bring it up. Anyway, this is Annalise. She's a large Vogue 2, and she is opera trained. And when I first started years ago, no one would be singing opera or playing a lot of instruments, and now a lot of the kids are doing that. Can you get that to play or no? No. Not playing? Okay. So these are all examples, again, of both 3s and both 4s that we're now doing our supplementary analysis, and I think that's going to validate what you see here, that these kids are very close to normal as far as their facial balance. So for me, why do I do the buccal flap approach? Well, I do the buccal flap approach because I really hate to have that discussion with parents that they need to have a secondary surgery for speech. And I really hate to have that discussion with a teenager that now, after all the things they've gone through, their surgeries, their bone graft, their orthodontia, maybe an anterior traction face mask, that now they need jaw surgery. So what do the parents want? They want to have a normal face and normal speech. So that should be the measure of what we look at as far as our palate surgeries. It should be normal face, normal speech without jaw surgery for speech surgeries. So and it should be done at skeletal maturity. So here's Luke, and he's now reached 18. And I looked at that same cohort of children, and 115 non-syndromic kids, 16 years or older, 91.3% can be achieved normal face, normal speech without jaw or speech surgeries. So now when Luke comes in, the discussion is, maybe we should do a little fat grafting to help your lip a little. He's still thinking about it. He just turned 18. Thank you very much.
Thank you very much. Our next speaker will be Dr. Buchman, and he will speak about buccal fat pad transfer.
Thank you. Shout out to Dr. Pape and also Dr. Ramposo and his wife. Dr. Ramposo was my fellow. He's doing very well and he helped to put this thing together, and I really appreciate it. Go Antonio. I'm really happy to say that the state of Michigan is sort of the place for some innovation for palate surgery. Bob and I go back way back. He's on the other side of the state, a little bit involved with that place up north that is having some problems now with their doctors and what they're doing. But you know, Michigan State, that sort of thing. So we're going to talk about actually at the University of Michigan now. And what I want to sort of bring to fact is that I think what Bob's talking about is a great thing to have in your armamentarium. I think that at the same time, I think that it's more suture lines, but I think it's certainly something that you should certainly consider. On the other hand, we've developed and sort of been pushing and working for a long time this buccal fat pad flap. The point of interest here is you know that people that know me know that I don't like to use alloplastic material in kids. The way I always tell my residents, if you're using an alloplastic material or using something that's from some cadaver, you better be right for 100 years, because if it doesn't turn out to be right, kids are going to live to about that by the time they get out there. I don't know if there's monkeypox or prions or whatever it is. When I was a medical student, we only had Hep A, B, and non-AB. Now I think up to H, J, K, L. It was always there, we just didn't know it, and that's how it works sort of forward in that regard. So we're going to talk a little bit about that. Complications of repair, obviously palatal fistula, transverse maxillary growth discrepancy, which is what Bob talked about, and restriction of midfacial hyperplasia, which is also what Bob talked about, which I think is true. Palatal fistula is anywhere between the 20 and 25% in large series, and I think it does matter. The residents doing the cases, what's going on, what are you looking at? Some of these statistics, you know, when they say BPI is like 2% and 3%, I'm sorry, I just don't believe it. And the reason I don't is a lot has to do with the speech pathologist and what you think is reasonable and what you think is not. So until they really come up with a way, I think you're going to have to look at what that is, but what people seem to think is acceptable, I think varies to the speech pathologist and the parents and what's going on from that standpoint. Also fistula sort of formation, again, each will have that there, but I think it's probably right around 10%, and that's probably true, and right around the junction of the hard and soft palate. So the bottom line is inadequate tissue, tension and palate. By the way, for all those people that think that that's the case, when they come to the other institutions, we write down where they're coming from because we must have one of those 1% or whatever it is when they come up with these places that say that they have 2 or 3%. It's really poppycock. The other part is that it's not just the palatal repair. That's what people don't understand. They're making it's all like about them. The odds that a congenital problem and that muscle is normal is a joke. I mean, we have a certain amount. There's a certain amount of that muscle that's not well developed. And for some reason, they think the whole thing is going to be a surgical repair, and it's not. So many times, inadequate tissue, tension at the palatal junction and closure, also tissue breakdown and fistula formation. So that transverse growth description is sort of caused by the palatoplasty and not necessarily affected by the timing or technique. And if you've actually been out and done missions, you'd know that people that are not repaired into China with can't. Sometimes we saw the widest clefts we've ever seen, beautiful maxillary sort of growth from that standpoint, and almost impossible at 5 or 6 years old to get that palate closed. Actually, those would be great situations for Bob Mann's flap. You can almost not get those things together because the palatines are so far across. So from our standpoint, there's inadequate tissue. We also leave, and this is the part that Bob touched on the other side, there's 2 parts of the reason why there's maxillary hypoplasia, we believe. One of them is because there's a lateral relaxing incision. The bigger areas you have, the larger incisions you get, and therefore you're leaving this large area for a scar to form. The other part, it goes back to the Schweckendeck idea, and that is if you don't lift these mucosas off that area, you get subperiosteal sort of, you don't lift the periosteum, you won't get hypoplasia either. In Bob's technique, you might get both, depending on where those things are. You don't get the scar that you have laterally, and hopefully you don't lift that tissue all that much. Both of those can lead to hypoplasia. Although I have to tell you, most of it is thought to be left from these large scars and these large areas of dead space that are out there. So what our thought is that you get secondary healing of the lateral hard palate, that leads to this transverse growth restriction as well as the hypoplasia that Bob talked about so elegantly. So inadequate tissue, secondary healing at the lateral hard palate, transverse growth restriction. Same thing with the tension at the palatal junctions. We know that that's where fistulas usually happen. So both of those lead to inadequate tissue. So right now, Bob and I are in the exact same place. We think there's inadequate tissue that's there, and you need to come up with another way to do so. Where could you get it? Well, one of the ways of doing it is alloderm, and you know as well as me, I think that's a terrible idea. I think it's terrible to put in kids. I said in the beginning, you know, who knows what's going to happen then? It adds an expense to the case. Who knows what you're putting in these little kids, cadaver stuff that's going to be out there, and I didn't want to be part of any lawsuits that are going to be out there when you're alone in there. But this is how they would do it. They put it in there with an extra layer to be able to get that done. But I thought an autogenous, durable, and vascularized alternative would be better, and that's why I started proposing and using the buccal fat pad flap. Now the buccal fat is really in the cheek. It's got 3 different lobes that are there, so it can definitely do it. The average weight is about 9.3 grams. It can cover an awful lot of space. The superior limit lies along the height of the vestibule above the maxillary second molar and opposite Stenson's duct. And it's been used before in head neck reconstructive applications. The area that what I did is it really hadn't been used in cleft palate repair before, and that's when I sort of brought it up, and it's a wonderful thing too, but it's been used for oncologic resections. So to describe the new technique of the palate repair, you do the repair just like we're talking about here, and then what you do is you take the buccal fat pad and you sort of put it in the area that's right there. You get set, right, you just put this beautiful vascularized area. It's no different than what plastic surgeons have done everywhere. You know, when you actually, if you have a butt sore and you don't use it, it's just like it contracts in, everything contracts in. So what do? You bring in great vascularized tissue like a flap, and the whole area heals, which is wonderful. So we do the furlough repair and a buccal fat pad flap. We're not going into that area with the hypothesis that this would add sort of added layer, decreased fistula formation, as well as prevent maxillary growth restriction. Now, unfortunately, Bob's been around a long time. I'm going to have to wait to get a little bit longer and so on to get them out. So I unbelievably respect these long-term results, and that's what we're going to have to show, and we are collecting them from that standpoint as they're going. But essentially, what we do is we do mucoperiosteal flaps just like you do. We skinny it on down to the vessel, just like was talked about between Dr. Hoffman and Dr. Mann. We bring those over, and we do a double opposing Z-plasty, just like was described. I do Z-plasty slightly differently, in that we do it more posteriorly, because I think laterally, then it's not tethered to the bone. If it's more posterior, it's tethered to the lateral pharyngeal mucosa, and therefore can actually move much easier and it's not tethered to the anterior sort of area that you have. Having said that, you've got that closure that's there. If you have those large, little lateral, hard palatal bones exposed, you bring your buccal fat pad flap in here. So this is now clinically what we're doing. It's an easy harvest to use. By the way, if you guys go and niche it, by the way, it doesn't cost anything either, from that. So the expense is not there, right? So you just go in there, you use your scissor, and you pop it right in there. Usually, for people that do orthodontic surgery, the buccal fat pad is a pain. So we put it to use. I mean, it's there. You go in there by mistake, it's sort of always around in some way. So you place a curved iris scissor in the superior border of the buccal sulcus, lateral to the maxillary tuberosity, and you sort of open that up, and it's truly a vascularized flap. You tease it out, you place it into, again, as you have this here, you place it into that defect. It'll actually come all the way up to the alveolar areas that you have. Look how well you can spread it, how robust it is, and then you just lay it right in there, and then you sew it both to the free edge and to the alveolus that you have that's there. And it's really done very, very well. We don't have, this is not even updated. Very few, if any, fistulas and so on. But the great thing about it is, look at this, in 2 weeks, this is what you have, mucosalized area that's there. We had a patient that came in, 2 patients that have come in from China, where they came in and they had lips and palates, but they were like a year and a half or 2. So we did a lip adhesion, and at the same time what we did was the buccal fat pad flap. So when I went back to do the lip, went back and did the palate repair. So when I went to do the lip, we took a biopsy. We asked them if we could take a biopsy of that area, and it came back normal palatal tissue. Now, I don't know whether that's stem cells from the fat or what's going on, but that's where it is. So they're easy to use, they're vascularized, they can be combined with furlough-paloplasty. In high tension areas, they can be used in that sort of area too. So I'm just going to go to show you a little bit of how this is now sort of advanced, because we think this can be used in other ways too. And part of that, as we go back, is to actually be able to put this in this area in between, what I call filling the void. And the reason I say that is if you look at what we're doing when we do a furlough, we're exonerating that middle lamella between the hard palate and the soft palate. And when you're doing that, what happens is not only do you have suture lines that are overlapping, and not only do you have 2 mucosal areas that are overlapping right at the area of the greatest tension, and an area where you may get palatal fistulas, but what happens to the muscles that are then being rotated back is we do a very significant, almost, a furlough brings in the muscle, but we almost have flaps of muscle that are off of that because we move it more posterior. So when we do that, you're really rotating those muscles around, which is now leaving a void in that particular area. What happens? What happens to that void? Why are there secondary areas that are there? Well, everything contracts, right? So what we talked about, if looked at VPI rates, can it be anywhere from 30% if you look at the kids that are out there? Only 15% surgical. Some people say 10 and 5%. That's fine. I find when they come to the university or come to other places and we watch them, people that are transferred, we're not necessarily as happy with what those things are. But you can do an IVV, you can do speech salvage after it's for straight lines. Arun actually does a furlough, even if a furlough was already done. I don't quite understand that, but he actually does them again. Seems to me you'd be putting things back, but he says he gets great results there. But you can redo a furlough to be able to get that done. Our point is that when you do these repairs, what you're doing in the middle area here is like saltwater taffy. You're pulling these areas right over there. These are the thinnest areas that you have, and the lamellas are missing in the midline. So this is a great thing, as you know, right? That in this particular case, this lady's walking around with her vacuum around nature, and nature abhors a vacuum, so she was a little bit scared as she sort of went there, and we should too. These are beautiful artistry. One of my fellows has a friend that's an artist, and you've seen this actually area. This is this vacuous area that we leave, and what we're saying is that instead of doing that, you can see where the muscle is that we put. Everything is sort of enclosed in here, and this area is where you get fistula formation, and it's also the area that the muscle and everything sort of will go back. And you'll see that's where the tension is. So where's that muscle going to go? And your palate going to go when this has to heal? It's going to go back, just like that. So our thought was that a medially placed buccal fat pad would decrease fistula rate and fill that void and minimize contraction. So we started doing that with our reviews. Again, I can go over this, but it's a 10-minute talk. We're trying to get there. I just want to show you the technique. We take that, we open it up. You can open this area just like we talked about before. I'll take it, and as you take it up, you take this beautiful fat pad out, and you go around the pedicle, around the palatine, and then you bring it underneath like that, and you bring it all the way across to the other side. You can see how robust this is. So now it is filling the void that's there. It just makes perfect sense. No alloderm.